So good afternoon, and thank you for joining us today. We have the great pleasure of having Dr. Meredith McCormack visiting us from Johns Hopkins. We're really fortunate. She's going to be talking about improving asthma health through the lens of precision medicine, a topic that is obviously really important to kind of population health, but also like clinically. And she has a lot of qualifications, a very extensive list of publications dealing with different aspects of precision medicine in asthma and COPD. She is the director of the Johns Hopkins Asthma Precision Medicine Center of Excellence. And her work is also has been, part of the major activities in the ATS, where she's the chair for the pulmonary function committee. Is it? Yeah. So I really appreciate you being here, and we're looking forward to hearing this presentation. Thank you.
Thanks very much. It's a pleasure to be here and really an honor to get to visit. So looking forward to the discussion at the end as well. Let's make sure I can. Great. And so these are the objectives. And these are my disclosures. And I won't be referencing any unlabeled or unapproved uses of drugs in this discussion. And I wanted to start with this. I think if we look around on the big screen, on our little screens, we see representations of asthma all the time, and it's often trivialized or thought of as a nuisance condition or something that's sort of affects the weak character in the plot. But in reality, the burden of asthma is really, I think, could be described as a national crisis. It affects millions of people. Millions have asthma attacks each year, and it accounts for many missed school, missed work days, and also accounts for deaths among our population. Asthma is also a condition that has marked health disparities. And so as we're talking today about approaches, thinking about the ways that we can ensure equitable evaluation and treatment of people across the United States is really critical. And the burden of asthma also is an economic burden. We spend billions each year in healthcare and in society that are attributable to asthma morbidity. And this is a framework that we've put forth as we're thinking about how to chip away at understanding asthma and understanding ways that we can impact this condition. Tomorrow, I'll be talking a good bit about triggers and environmental factors, but we also conceptualize internal and external factors in terms of host susceptibility and how these may lead to asthma exacerbations. And I think as we're moving towards precision medicine and personalized medicine approaches, we see this reflected in our guidelines. And here we see our national guidelines on the left and our international guidelines on the right, the GINA guidelines. And I think talking about advances and what makes asthma exciting, an exciting space to work in, we have to include the recent changes in the guidelines and how we think about management with use of our inhaler therapy, including SMART therapy or MART therapy, with the idea of using one inhaler for maintenance and reliever therapy. And this top line was just a heading of an editorial published years ago in the European Respiratory Journal, really describing this change in our asthma guidelines as the most fundamental change that had occurred at that time in the last several decades. And here's a representation. When we think about managing and assessing our patients with asthma, we describe it by the treatment step they're on, how much treatment is required to achieve asthma control. So absence of symptoms, not having an asthma attack, ideally achieving normal lung function. And asthma is described as worse as it requires more medication to achieve control. So as we go up the steps. And here we see the changes that were put forth in the GINA guidelines initially the idea where we would switch from using albuterol as our rescue medication to using an inhaler that contains an inhaled corticosteroid, in this case, an inhaled corticosteroid and formoterol containing inhaler. And this is also mirrored, not exactly, but very similarly in our national guidelines, where we see the use of a combination inhaled corticosteroid and long-acting beta agonist, using it with a maintenance dosing as well as needed as we're going up the treatment steps. So if you're here in person today, you have a party favor, which may be at your desk, but this sheet, while it might not be the most groundbreaking scientific advancement, to me as an asthma care provider, is my most important tool. And so there, if you're at home, or at your office, there's a QR code and you can get to this online. We have this in every room in our clinic. And I use this as a tool. I just slide it across the desk and I ask my patients to point to what inhalers they have. And then I ask how often they take those inhalers. And often they're pointing to multiple inhalers in the same category. Sometimes the inhaler they're pointing to doesn't match what's on their medication list. And almost every single patient, I learn something from going through this exercise. And I go through it every single visit. My patients who come back frequently, we just slide it across, they know what's coming. And it really opens up a lot of conversation about when they take their inhalers, how they take their inhalers, the ones that are lost, the ones they don't even know what they are. So that's probably the most important takeaway, is that this talking about inhalers and how they really are being used in real life and what the barriers are is probably the way we can all make the most impact in caring for patients with asthma, in my opinion. And one other detail is if you're using an asthma action plan, which I recommend, and you're using MART therapy, this single maintenance and reliever therapy, make sure that your asthma action plan also reflects that. And this is just an example of one, which was published in an article that really addresses the practical aspects of implementing SMART therapy. And so I recommend this article and also just this example of including this in your bundle of the way you treat patients. So I wanted to move to a case. This is a patient that I've been caring for years. She is 56. She was diagnosed with asthma at the age of 16. Her triggers she described as including pets, perfume, smokes, cleaning products. And she initially improved on medications, but she came in with a lot of increasing symptoms and was requiring prednisone to achieve control. She told me that she was on inhaled steroids, LAMA inhalers, as well as montelukast. But she also described that she didn't always take her medicines. She didn't always take her inhalers. She often forgot. Other things that were important, she was a never smoker, but she lived with her sister who smokes. She had several pets, including a pet guinea pig, worked as a dental hygienist, and had wall-to-wall carpeting in her bedroom. Her exam, she had, on her lung exam, she had expiratory wheezing. Her other aspects of her exam were notable for the fact that her BMI was 40. And her spirometry shows the classic concavity in the expiratory limb of her flow volume loop and a decreased FEV1 to FVC ratio, demonstrating her airflow obstruction and impairment of her FEV1, described here as 55% predicted, but if I was really current, I would have given you a Z-score. For another talk. So she has moderate airflow obstruction. So this patient falls into this difficult to treat or severe asthma. And I find this a little bit confusing, at least in the terminology. So just to walk through it, right now she's difficult to treat. And I'm wondering whether she's severe. And the distinction there is she's admitted and told me that her adherence isn't great. We have some environmental factors that we can optimize. And so until those things are really addressed, we don't classify her necessarily as severe, but she's in this area of poorly controlled, requiring a good bit of medication, but we're not sure what she's getting. So again, this is someone where it was really important to try to optimize adherence. And so we worked on making sure she used proper technique. working on some strategies to help her remember and have access to her medications. And we improved over time. We didn't probably get to perfect, but she made a lot of strides. I like talking about her case because it was very interesting. I sent RAS testing, and it was notable for allergy to dust mite. I also added in guinea pig. I wasn't even sure like how you order guinea pig, but I checked a box and this came back. And so when we went back, she had profound symptoms when she would even walk by her son's room where the guinea pig was. So there's a whole guinea pig chapter to this tale that was for another time. But that was an important driver, and mouse. So there also is good evidence, in particular in Baltimore, we know mouse allergen is a big driver of asthma. And so sometimes I add this on, and in this case, she also, pest allergen was another area we wanted to really focus on with integrated pest management. So this is small, but this is just an example. The backside of this asthma action plan, which is put forth by the NIH, has a really nice schematic of different environmental control strategies. And so if you're using an asthma action plan, this is another one to think about, because this is a nice way, and this could be put into your electronic health record, to also cover some of the environmental control practices and deliver that to patients. So I think for this patient and others like her, she's clearly, she ended up falling in the severe asthma category. She would continue to be poorly controlled on maximal step 4 therapy. And we were thinking about alternate approaches. And so really characterizing her in terms of her phenotype was part of the work of treating her. And she fell into, we see here, the allergic asthma. She had child onset, she had eosinophilia. But as we're understanding asthma and the heterogeneity within asthma, there are other phenotypes that are important to consider, including T2 low asthma, obesity-associated asthma, and often these are in the context of adult onset. And what are the tools when we're trying to define a phenotype and endotype? Some of them are shown here, and we see clinical characteristics as well as blood biomarkers, eosinophilia being a really important one, as well as IgE. Sputum biomarkers are often difficult to apply clinically, and there's exhaled nitric oxide, which can also, or FeNO, which can also tell us about eosinophilia in the airway. And from this, we can approach tailored therapy. And this is a schematic. If we think about the environmental drivers of asthma and the biologic response, we see these different mediators of inflammatory response. And in this schematic, we see allergic, eosinophilic, neutrophilic, and so forth. And some of these mediators, as you're familiar with, have therapeutic targets that have now been identified and have actionable interventions in our biologic therapies, including IgE, interleukin-5, IL-4 and IL-13, and more recently, TSLP. And we see that most of these are falling over on the eosinophilic and allergic side of the pathway, and the most recent anti-TSLP biologic therapy also having an indication for our non-allergic asthma. And so really, I think a very exciting part of treating patients with asthma today is that we have these new therapies that are for our patients with severe asthma. And here we see omalizumab, which has been on the market for a while, targeting IgE, as well as mepolizumab, reslizumab, benralizumab, and dupilumab that are all indicated for eosinophilic asthma. So for our patients who have a peripheral eosinophil count greater than 150, and tezepelumab, which is now indicated also for, not specifically for patients who have eosinophilic asthma. These are, except for reslizumab, available for home injection, which has really been a huge advancement in the care and the patient-centeredness of these approaches. And it's also important to note that there are co-indications for many of these biologics. For example, mepolizumab is also indicated for nasal polyposis, as is dupilumab, as well as dupilumab is also indicated for eosinophilic esophagitis, as well as atopic dermatitis. So there's often a co-benefit in our patients that have these comorbidities, where you can actually be improving 2 of their conditions with one therapy. So this was actually the first patient I started on biologic therapy, and she had a dramatic improvement. When she came back, she had described that she was now able to walk around her neighborhood with her kids. She used to have to sit on a bench, and really described in a lot of detail what she used to have to do versus now. She had lost weight. I think the first time I saw her, she had lost maybe 10 to 15 pounds without even trying, just by moving around more. She had an incredible change in her quality of life. Over time, she continued to lose more weight and was able to avoid prednisone, and she had really been prednisone dependent. So just an example of the remarkable improvement that we see in many of our patients. So I wanted to talk about going back to the biomarkers and the way that we characterize individuals. I wanted to share some work we've been doing looking at airway biomarkers. And this is work in collaboration with Megan Rabuli and Neil Alexis at UNC. And one of our fellows, Anna Cho, has been working with me collecting nasal epithelial lining fluid. And I don't know if any folks here have been using this technique, but it's very nice because it's non-invasive. You put 2 small strips of paper in the nostril, squirt saline solution, and then clamp the nose for 2 minutes. We freeze this and analyze it in batches. It's actually for our study, it was analyzed at UNC. And we applied this in a cohort study of children with asthma. And we recently looked at some of the results. And here we're comparing, I think this is in about 85 children with asthma. And we were comparing the profiles of their nasal epithelial lining fluid cytokines to, and here we're binning them by children who have an eosinophil count greater than 300 shown in red versus less than 300 shown in blue. And what we see here is that our T2 cytokine profiles were expressed more highly in our eosinophilic children with eosinophilia compared to those with lower eosinophils. And then if we looked at our non-T2 cytokine profiles, we saw the opposite. So the children with lower peripheral eosinophilia had higher expression of interferon gamma, TNF alpha, interleukin 1 beta, as well as IL-2, 17, and 8, for example. And then we also compared this to their FeNO concentrations. So their fractional exocyl nitric oxide concentrations, again, high in red and low in blue. And we saw very similar binning of the groups such that the T2 cytokine profiles were more highly expressed in those with higher upper airway inflammation, and similarly with lower. So I present this just as a potential tool in the future where we may be able to even be more specific. And I think this is a possible tool that we can use. It's very non-invasive to look at airway inflammation with greater granularity, and could be something that we could look at response or other ways to think about answering questions in the future. So we go back to our phenotypes. So this patient clearly fell into the T2 high classification. But what about her imaginary cousin, patient DB? And this is a patient that's similar to many patients that we see probably. 56-year-old female, diagnosed in adulthood, triggered by more like irritants, so viruses, scents, doesn't have eosinophilia, but also has an elevated BMI. So the obese or overweight asthma phenotype is something that we've been really thinking a lot about, in part because of the burden of this issue and the prevalence. So more than 40% of the people with asthma living in the United States are obese, and obesity is associated with more severe asthma that's refractory to first-line therapy. And while weight loss is a great solution and probably the ideal solution, it can be very hard to achieve. And so there are probably many different ways that, many different factors that are associated with obesity that drive the increased morbidity that we see in this subgroup, including diet, maybe microbiome, environmental exposures may enhance susceptibility, and I'll talk about that a little bit more tomorrow. There may be mechanical effects, but we were specifically focused on conditions related to metabolism. And if we take a minute just to think about the history of diabetes and dysglycemia that is the underpinning, this is a schematic of the natural history of dysglycemia. And you see here, this is the onset of diabetes, and on the x-axis are years. And so we see that there's a slow increase in fasting and postprandial glucose concentrations that really precede the clinical onset of diabetes. And also in the background here, we see increases in insulin, reflecting insulin resistance. And then here, the decrease in the insulin responsiveness and the increase in risk of hyperglycemia as diabetes progresses. But one of the things that's captured in the schematic is there's probably a period right here that may be an opportunity to intervene. So keeping that in mind, why do we think that this is relevant to asthma or to the airways? There's evidence from translational models suggesting that hyperinsulinemia activates airways smooth muscle, creating a hypercontractile phenotype. Also, evidence that hyperglycemia has been linked to airway inflammation, oxidative stress, and fibrosis. Some evidence that this may be related to restrictive lung disease as well. Animal studies, including mouse models, have demonstrated that metabolic syndromes associated with airways hyperresponsiveness in normal weight mice, and that hyperinsulinemia and insulin resistance also potentiates bronchoconstriction among obese mice, again, inducing airway smooth muscle hypercontractility. There's also some evidence in mouse models that metformin attenuates eosinophilic inflammation and leads to improvements in airways responses potentially through TNF alpha. And so if we look to human studies and the relationship between metabolic dysfunction and asthma, Eric Forno has contributed significantly to this work. And this is an example of his work from N. Haynes looking at adolescents. And he looked at different, and he and his team looked at different indicators of metabolic syndrome. And here we see over 1,000 adolescents binned by control, metabolic syndrome, asthma, and then both conditions. And we see that individuals with insulin resistance was associated with lower lung function, here specifically lower FEV1 to FVC ratio, so prevalence of airflow obstruction. And this was more pronounced in both conditions. Individual or groups in Denmark conducted a population-based study looking at incident asthma-like symptoms and found that insulin resistance, prediabetes, as well as diabetes was associated with significantly increased incidence of asthma-like symptoms. And there's also evidence suggesting that metabolic syndrome is related to increased prevalence of asthma. And this is a meta-analysis looking across many studies, including other work by Eric Forno, suggesting that this is increased prevalence of asthma among those with metabolic syndrome. So we were interested in looking at what happens, what is the effect of metabolic syndrome and specifically hyperglycemia among individuals with asthma. How does that relate to their asthma morbidity? So this is some work that I did with David Wu, who's now at Baylor, and he really has focused on this as part of his current K23. And this was our first piece of work. So we looked for we had a data set, the Truven IBM market scan data, which is data on generally a healthier cohort of people that are employed, claims data. The average age was 50 years. And we looked at a subgroup of obese individuals who had available hemoglobin A1C measurements that also had a diagnosis of asthma. And this is what we found. This is the relationship between hemoglobin A1C and the risk of having an asthma exacerbation. And this is the pre-diabetic range, and this is the diabetic range. And what we saw was a nonlinear, but an increased risk of asthma exacerbations with increasing hemoglobin A1C concentrations. such that there was about a 30% increased risk among those who had prediabetes and diabetes compared to those that had normal hemoglobin A1C. And so we really went at this because we were thinking about whether metabolic syndrome could be a therapeutic target for this phenotype that has pretty limited options right now. And so we looked to metformin. Metformin is the first-line treatment for diabetes. It has probably a multitude of pathways by which it works. And several of the candidate pathways include AMP-activated protein kinase dependent and independent mechanisms, including those that act through peripheral as well as hepatic insulin resistance. There also have been studies demonstrating anti-inflammatory properties of metformin, and it also inhibits fatty acid synthase. Our conceptual framework, as we were thinking about how it may apply to asthma, is whether it could work through IL-6, through insulin resistance, or through the dysglycemia and the constellation of things that are associated with diabetes. So we looked again to larger data sets to see whether there could be some evidence to support this concept. And this was a study we did looking again at the IBM market scan, same data set. And we looked at metformin compared to the cohort and then a matched cohort, and saw that there seemed to be a protective effect of metformin in asthma exacerbations, in particular ED visits, as well as hospitalizations. And this is the graphic that went with that. And the metformin initiators here in the dashed line compared to the solid comparator group. And we found there was a protective effect both when it came to ED visits as well as hospitalizations. There are limitations to this data. It's claims data, so there are not a lot of individual characteristics. We're looking at obesity by ICD code, so there are definitely some limitations to those inferences. So we followed this by looking at our electronic health record data and through the Johns Hopkins healthcare system. We created a cohort of about 7,000 individuals, and 1,800 of them met criteria for diabetes. We were able to adjust for specific individual characteristics, things like age, race, smoking, BMI, insurance status, and so forth. And again, found here we see the propensity matched subcohort that there were protective effects associated with metformin when we looked at oral steroid prescriptions as well as emergency department visits. We didn't meet statistical significance for hospitalizations, but the number of events was relatively small. And finally, we looked at the same question in the COPD gene. We were wondering whether this could be also a phenomenon that would be pulled up with when we looked at a COPD cohort. We didn't find as strong of a signal in the overall cohort of COPD participants that are enrolled in COPD gene, but we did find a stronger signal in those that had a concomitant diagnosis of asthma. So we felt that this was supportive. Here we see the asthma COPD overlap group looking at total exacerbations and then severe exacerbations, again, looking at metformin as the exposure. So our next step is we just received funding to conduct a pilot study looking at metformin between Baylor and Johns Hopkins. We'll be enrolling 50 participants to demonstrate proof of concept and to look at we think our primary endpoint will be asthma exacerbations, but we'll also be looking at other endpoints. And we think that that idea of being able to ultimately conduct a larger trial and then potentially nest ancillary studies to try to disentangle which pathway may work is sort of our ultimate goal. And so metformin, we think, is, and potentially other drugs that are targeting metabolic syndrome, and I think there's some really exciting new ones as well that are also very effectively achieving weight loss, may be effective treatments for patients with asthma. Really thinking about an outside-in model where we're treating systemic inflammation, systemic drivers that may have an airway consequence. And also just thinking about whether this may be a treatment that could be made available for those with T2 low asthma, for which there are fewer available treatments. So when we think about the framework, really, we have good treatments for T2 high asthma. We think that metabolic inflammation is a potential candidate for T2 low. Thinking about personal drivers like adherence and medication response, it's important to think about how we may improve the lives for our patients with asthma now. And then tomorrow I'll be talking a little bit more about the environmental drivers that may be important at a population level as well as at an individual level. So to me, what some of the things that make asthma really an exciting space to work on are the way we're thinking about new customized approaches to approach our inhaler therapies for our patients with asthma, the advent of smart therapy, the promise of biologics for our patients with severe asthma, and customizing those approaches potentially with new novel biomarkers that may be more readily accessible in the future to try to really drill down onto which pathway may be driving their disease and finding a precise intervention. And then the future, maybe for those with obese asthma, that may be targeting metabolic inflammation. And our hope is that through using, on our team, using data from the electronic health record and building a biorepository as a companion to this to advance discovery to really better phenotype, endotype, and subgroup our patients so that we can advance discovery and develop new biomarkers and ultimately the therapies to address the new targets. I want to acknowledge the really large team of folks that we have working in this space, including the space of environmental drivers. The Breathe Center, our focus is on environmental determinants of health disparities, which I'll talk a little bit more about tomorrow. And I know that Sandy Zay has been working as part of our group, including thinking about asthma adherence. David Wu, who's at Baylor, contributed a lot to the metformin and metabolic syndrome work. And we have a whole team behind us, including our participants who have participated in our studies. I hope that we can open it up for discussion, but I wanted to keep it a little bit short because I was hopeful that we can have some interaction.
Any questions?
Thank you very much. That was very nice. I think what's interesting about the metformin data that you
Yeah.
have is that in contrast to the SGLT2Is or the GLP-1s, metformin tends to be weight neutral, doesn't cause this type
That's
of
right.
weight reduction. So you can really isolate, is this metabolic, is this obesity driving it? I did notice in your precision framework, you had sleep up there.
Yeah.
And I was curious, there is a literature, at least in the sleep field, about sleep disorder breathing and asthma exacerbations. I'm wondering, do you think about that when you see patients in clinic? I
do. And thank you for that question. So the question is related to the intersection between sleep and asthma. And I think my reading of that literature is there's probably arrows going both ways. And particularly when I think about environmental drivers, one project that we're working on now, I have a study in children with asthma who we've done a lot of work looking at drivers of asthma from the environmental standpoint. So air pollutants and allergens in the home that may provoke asthma. We actually think that they may also be provoking sleep disorder breathing, as well as other things. And then there could be a common pathway there. And so that's actually an active study that we have trying to look at the environment to sleep to asthma. We're using the nasal epithelial lining fluid cytokines to look at whether there's an upper airway and a lower airway component. But I think so I'm very interested in these questions, but I think also if you're taking just the piece of sleep and asthma, the idea of a unified airway and whether or not breathing patterns and the things that are influencing those patterns, be it leading to sleep disordered breathing or airways hyperresponsiveness, could be common. And then also, I think the literature, leukotriene modifiers have been shown to make some impact in sleep disordered breathing in some studies, and also are part of our Obviously, there's evidence in asthma. So I think thinking about unifying those concepts and thinking about ways that we can approach treatment, I think there's a lot of work to be done in that space. That's one of the data elements that we have in our precision medicine armamentarium to try to start looking at those relationships, hopefully at broader scale.
Okay, I have the
Yeah.
microphone, so I'm going to ask a question. So I love the idea about having better biomarkers, because our biomarkers are terrible. But of course, you know, you don't get better but they work for the biologics we have.
Yeah.
So I was looking at your nasal washings and thinking, well, IL-8, look at IL-8 there in the nose. And we don't really think as much about, I know there are studies using IL-8 out there. I think our our Precise trial has an anti-IL-8, but where's Jeff? He's on the Zoom probably. So I'm wondering about IL-8, and I'm also wondering, you know, at this point, how do you see more biomarkers coming into this in terms of like beyond the gross T2 and non-T2? Because it feels so, you know, we wish, but I'm not sure they're going to be that helpful at this point.
Yeah, I think your point is very well taken, right? I mean, we have eosinophils are our most prominent biomarker, and it's not all that novel. And I mean, a good thing is that you can get it from any electronic health record. It's often used in population health, right? So it's a very readily accessible indicator that we can use to study and also to classify patients.
And also
it doesn't
works for the biologics, right? You're high.
Yeah, exactly. That's what I'm saying. Like, so that's but it's not all that precise or refined. That's why we're interested in the nasal epithelial lining fluid, if that really is an indicator that can give us some more specificity. I think it's a very interesting tool. I did have a couple other slides related to that finding.
I mean, at this point, we don't really need specificity. So I want it to be useful.
Yeah.
But it, you know, to date, it hasn't really shown to be very helpful, right?
Yeah. So this was a couple extra slides that for our patients, for the same cohort that we had of children with the nasal epithelial lining fluid, we looked at the relationship here between maximum symptom days, for example. And this was interesting. We found only in the normal weight children, there seemed to be a relationship between our nasal biomarkers and this asthma outcome, which was symptom days, which we didn't find in our overweight and obese children. And we looked at that in two different outcomes. The other one was the asthma symptom utility index score, which seemed to be specific for our normal weight. But I think that's just an example of a type of method that could be used. And if this really were put forth beyond a research tool, like if it was borne out, then that's something you could use maybe to look at treatment, to define responders, to look at how treatment is affecting the inflammatory milieu of an individual, the airway inflammation. And so I think that's an example of something that could be developed in the future, but I agree, our biomarkers currently are very crude.
So in your study with metformin, I was wondering if you noticed any change in actual lung function itself with metformin use, just thinking about determinants of lung function.
Yeah.
And then the other question I had was thinking of how the mechanical effects of obesity affect lung function. How can you attribute an improvement in clinical endpoints to an improvement in the mechanical effect of obesity versus an improvement in the metabolic changes or milieu?
Yeah. So the question was whether or not I think part of the question was whether or not we think that metformin may have an impact through lung function change. And we haven't been able to look at that yet because we were looking first at claims data and then at electronic medical record data that didn't have a lot of repeated measures in lung function to look. That is a question for our pilot trial. And specifically, we're characterizing all of the individuals with mannitol airways hyperresponsiveness testing at baseline and then at the end, because I think that one of the biologic pathways, which we think is compelling, is whether or not metformin could work by ameliorating airways hyperresponsiveness. So I think that is one of several candidate pathways. Though that is challenging in clinical trials, it can be challenging. So part of the work of the pilot is to look at the feasibility there, and also to look at how the eligibility, how many of our eligible participants will have airways hyperresponsiveness at baseline, and what that will mean in terms of recruitment and designing a larger trial. So that's definitely of interest, and part of the work of this pilot study is trying to walk that down to see what it would mean in terms of designing a larger trial.
Thank you, Meredith. That was really very interesting. So I have a couple of quick questions. One is, with regards to the sexual dimorphism in our patients with asthma, for example, would you anticipate to see a difference in the response to metformin in your trial? Is that something that you're looking at? And the other question I have is, once you class somebody into one of these endotypes, so you can treat them with a biologic, is there a way to anticipate, based on biomarkers, for example, who will respond more or less to the drug, or the subgroups that respond better or worse?
Yeah, so go through I should repeat your questions. Sexual dimorphisms, and then thinking about biomarkers to predict responsiveness. So sexual dimorphism, I think in terms of the response, the obese asthma phenotype, I think if I were going to pick a question to really think about different sex differences, I think that's a really good subgroup to be thinking about these changes. Certainly with in women, we see increase in differences post-menopausal, and thinking about whether that could be part of the signal, whether there could be hormonal influences that are also driving some of the effect in this subgroup. I think is a really, it will be an important part of that work. Potentially it's something we can look at as we're aggregating larger data sets that have individual characteristics, and either with existing data or by adding a biorepository to be able to more specifically look at some, sex differences in that way. I think that biomarkers as a predictor of responsiveness as responders or non-responders, as well as trying to understand the pathways by which people are responding, or individuals who may respond better to one biologic, but then either fail one biologic and then are successfully treated with another, and whether we could determine the likelihood of responsiveness by, for example, looking at their airway cytokine profile. I think those are some questions that I'd like to see answered with these more accessible techniques. Yeah.
We have a couple of questions from the chat here. There's one question, how to distinguish rhinitis from asthma using those cytokines?
Yeah, so one of the things that we're looking at, I think you were talking about the nasal epithelial lining fluid cytokines. We do have questionnaires, for example, on rhinitis, but even back to the sleep question, the idea of a unified airway and whether or not features of rhinitis or sleep disordered breathing or other conditions that are more upper airway predominant, how those either impact are related to the lower airway drivers, I think are really good questions. And then so far, we're looking at whether or not the rhinitis, for example, the cytokine profiles may be predictive of who has rhinitis. We haven't seen a great signal, but this is sort of exploratory now.
Second question here is, what's the correlation between the epithelial lining fluid levels with maybe systemic levels like blood levels or BAL or sputum in your population?
Great. We do, the other biomarker we have in this cohort is peripheral blood. And so we have looked at that. We don't have complete overlap on all of the biomarkers. We have about 6 or 7 of them that have overlap, and the correlation is modest. So what we think that means is there's some correlation, but that these are really getting at different compartments. And so the nasal epithelial lining fluid being a surrogate or a direct measurement of the airway and a surrogate for the lower airway. But we are going to be digging into that a little bit more. The serum markers are just coming back. So we're trying to figure out if we can make some, to combine those data to try to better develop phenotypes.
Question from Dr. Mathey. Are you finding fewer inpatient admissions at Johns Hopkins?
In general, during COVID, we certainly had a reduction in our asthma admissions, asthma hospitalizations, I think as we saw nationally, but we're actually, looking at those data. And so that was dramatic. We're now seeing an increase back currently to close to our baseline levels. A couple other things that I think were relevant here as well. We were looking back at our data, for example, in June when we had wildfire smoke come down and we saw a spike in our admissions, as you might expect. But I think that's the kind of questions that we can look at, is to look at prevalence and trends. I'm interested too in terms of thinking about RSV vaccination and other viral trends, and being able to look and see whether we can try to understand protective factors or risk factors, thinking about those different types of trends by using the data we have in our electronic health record. Go ahead. That's a good question. I've been thinking more about, does discontinuation of metformin have an impact on asthma? And so I think we're still really at the early stage of answering that type of question, but I have many patients who are on metformin already for a different indication. And so, so I don't really know the answer yet, but it's definitely, if we prove that it's effective, I'll be interested to see how long you can sustain the response.
One of my questions is, what are your thoughts in terms of like the accelerated effect that's, like when we're treating patients for exacerbations, right? Typically doing it with systemic corticosteroids for those severe exacerbations. Do you think that there's like an accelerated development of metabolic syndrome or diabetes as a result of that? And perhaps what we see is a surrogate of kind of like maybe more disease activity or also kind of severity, because we also know now that inhaled corticosteroids can also have some metabolomic effects. So any comments on that?
Yeah, I think I think the question was related to the fact that our treatment for asthma, steroids, and even inhaled corticosteroids can lead to the development of obesity. And so how do you disentangle that? And I think also you're describing a cycle, right? Where we have a refractory group to our first line therapy, but part of the therapy, the prednisone that we give these patients has contributed to their obesity. I think the patient I described is a really great example of that. That patient didn't have a weight loss intervention. She had an asthma intervention. And I would say she was my first patient on a biologic. The first 3 patients I had were so just amazing. The difference, people that had been living with asthma, who had been chronically on steroids, missing work, came in, and now we're just completely different people, really, in a major way. And she went on to lose, probably 20 or 30 pounds just from having her breathing improved, being able to walk around and do normal life things, and not making a lot of other changes besides being more well and healthy. And so I do think that kind of speaks to your question, is that our treatments were really pushing her into this overweight and obese category. So I think now we have more new agents across the board in the space of endocrine and weight loss. So it'll be exciting to see how that impacts our patients. Yeah.
Of these, what you think is going on?
Yeah, I think so the question was about patients who respond to perfumes and I would say airway irritants. And a couple things I would say about that is I've been hearing this for years, and I think the world has maybe become a little more empathetic to this response. And also some of those patients will have really benefited from masking. And I think as masking has become more part of our culture, people that have that sensitivity, that's really a part of the syndrome of asthma, have a new approach that they can take that's generally pretty socially acceptable. And so I would say that's a very real response. I have many patients who will say, like, they walk by the Yankee Candle Company in the mall, it provokes symptoms. They're doing their laundry, you know, different things, cleaning agents, perfumes, scents, and they're all around our environment. And so sometimes I think now we have, with masking, people can have a choice that's more socially acceptable to protect themselves. It's not ideal, but I think many patients do that. But it's certainly part of the driver for many individuals. And whether that's part of a phenotype, it probably is, but the biomarker, I'm not sure we have.
And then the other overlap
Yeah.
with these patients tends to be, as you already referred to, upper airway.
Yeah.
Which can be a mixture of rhinitis and vocal cord.
Yeah. I mean, irritable larynx and vocal cord dysfunction, I think, is something to be mindful of in the right clinical context, and can overlap with people who have a more of an irritant response. That is definitely something I think about.
All right. Any other questions in the chat? All right. Well, thank you so much for this great presentation.